Greetings from Indian Journal of Anaesthesia. I, Dr. Reniki Sharma, will be presenting an article published in the September 2024 issue of Indian Journal of Anaesthesia. It is titled A Randomized Control Trial to Compare the Occurrence of Postoperative Nausea Vomiting in Early versus Conventional Feeding in Children Undergoing Daycare Surgery under General Anesthesia. Now, IRA's guidelines recommend early enteral feeding in neonatal intestinal surgery, but the timing is still unclear. Older protocols suggest 4 to 6 hours of postoperative fasting to reduce vomiting and hospital stay. Recent studies have shown that early postoperative feeding may not increase the nausea vomiting postoperatively, but may be beneficial instead. So this study aimed to compare the occurrence of postoperative nausea vomiting between early oral feeding and conventional feeding in children undergoing daycare surgery under general anesthesia. So the primary objective of this study was to find out the incidence of postoperative nausea vomiting in children getting early feeding as compared to those where conventional feeding was given. The secondary objective was need for antiemetics, postoperative pain, postoperative analgesia, duration of hospital stay, and parental satisfaction between the two groups. The ethical approval was taken from Institutional Ethics Committee, and the trial was registered in Clinical Trial Registry of India. It was a randomized controlled trial which included children from age group 3 to 10 years of age and ASA grade 1 to 2 undergoing daycare surgery under general anesthesia with caudal block. Children with history of motion sickness, difficult airway anomalies, any gastrointestinal disorder, and children having contraindication to caudal epidural anesthesia was excluded from the study. So the patients were randomized into two groups, group EF that received early oral feeding and group CF that received conventional feeding. All the children underwent routine investigations and pre-anesthetic checkup before surgery. They were kept fasting for 8 hours for solids, 4 hours for milk and semi-solids, and 2 hours for clear fluids. Inside the OT, the routine ASA standard monitors were attached like SpO2, ECG, and NIBP. And before inducing anesthesia, computer-generated random sequence allotted, a simple random sampling was done. And the allocation concealment was done in an opaque envelope by two authors. The third author opened the envelope and assigned the patients to the respective group. GA was induced by via institutional protocol. If IV cannula line was there, then intravenous induction agents were used. Otherwise, induction was done by inhalation agent and a supraglottic device, preferably a IJA was inserted. After induction of general anesthesia, caudal epidural was given in the lateral position with 0.75 ml per kg of 0.2% ropivacaine and clonidine 1 mics per kg. Vitals were monitored intraoperatively, and at the end of the surgery, the patients were reversed. Intraoperatively, IV fluid, crystalloids, ringer lactate, or plasma light was given according to the Huligeri formula. In the postoperative period, the group EF patients received carbohydrate containing oral fluid as soon as the child demanded feed after anesthesia. In the group CF, the children received carbohydrate containing oral fluids after 4 hours of anesthesia. The carbohydrate containing fluids were 5% dextrose, apple juice, milk, mango drinks, and orange juice. The children in each group were offered as much as fluid they wanted, up to 10 ml per kg per hour, and this was recorded. The maintenance fluid that was started till the oral feed was started was based on the Huligeri formula. The vomiting was assessed at half-hour intervals for the first 2 hours and hourly till discharge, and the incidence was noted. The assessment of PONV was done by the resident in the post-anesthesia care unit or by the nurse and doctor in the ward, and if required, the parents telephonically call the authors. The post-op nausea vomiting scoring system ranged from 0 to 3, 0 with no nausea and vomiting, 1 with nausea alone, 2 is vomiting once in 30 minutes, and 3 is persistent or 2 or more episodes of vomiting in 30 minutes. If the score was more than equal to 1, then ondansetron 100 mics per kg was used as a rescue antiemetic. The pain scores were assessed by the FLAC score, the face, leg, activity, cry, and consolability scores, which was assessed after feeding and every 30 minutes in the first 2 hours, hourly for 3 hours. If the pain scores were more than equal to 4, then paracetamol 20 milligram per kg was given as a IV rescue analgesic. The incidence of emergence delirium was noted. Post-operative complications like desaturation, reintubation was noted. The parents' satisfaction score was noted, which ranged from 1, which was very satisfied, to 5, that is very dissatisfied. And the authors telephonically questioned regarding the PONV episodes till the first 24 hours after surgery. So the primary outcome was to find out the incidence of PONV with early oral feeding compared to conventional feeding. And the secondary outcomes were need for antiemetics, postoperative pain, postoperative analgesia, duration of hospital stay, and parental satisfaction in between the two groups. The sample size was based on previous study where the expected incidence of PONV was 11.4% with early feed and 23.9% with late feeding, and at 95% confidence interval, 80% power, and 5% dropouts. The sample size was 300, that is 150 per group. And a p-value less than 0.05 was considered significant. So this is the flow diagram where a total of 560 patients were assessed for eligibility, out of which 150 were analyzed in each group after randomization and loss to follow-up. So this is the table showing the baseline characteristics between the two groups, which is similar. This is the table showing the incidence of PONV. The incidence of PONV did not differ significantly between the two groups. However, the time to first post-surgical feed was significantly higher in the conventional feeding group than the early feeding group. The pain scores in terms of FLAC scores were significantly higher in the conventional feeding group in the immediate postoperative period, 30 minutes, and after 1 hour. The rest of the parameters did not differ significantly between the two groups. Like the time to rescue analgesia, dose of analgesia, and the patients requiring analgesia were comparable between the two groups. However, the early feed group had significantly shorter duration of hospital stay, and the parents also had better satisfaction scores. No patient developed feeding-related complications like aspiration, need for reintubation, etc. So early feeding in children undergoing daycare surgery under general anesthesia resulted in similar rates of postoperative nausea vomiting compared to conventional feeding. The children in the early feed group had better pain scores, shorter hospital stays, and higher parental satisfaction than the conventional feed group. The previous studies have shown benefits of early feeding such as reduced thirst, early return to normal diet, quicker ambulation, and enhanced recovery. No complications were noted in the early feed group as feeding was done cautiously when the child was fully awake. The parental satisfaction was higher in the early feed group due to reduced hunger and distress in their children, highlighting the importance of early feeding on quality improvement. The main limitation was the inability to blind participants to the intervention, though randomization and allocation concealment was ensured. So to conclude, from this study, early postoperative feeding in children undergoing lower abdominal non-gastrointestinal daycare surgery under general anesthesia does not increase postoperative nausea vomiting. Early feeding is associated with a shorter hospital stay. Improved parental satisfaction is observed with early feeding compared to delayed feeding regimens. Thank you.